Now, I do hope that anyone who's been out there sitting CRQs and SBAs for the final FRCA this week are having a tolerable time. It is almost over, folks. I want to just quickly say that this show is going from strength to strength, and that is in part because you guys are listening, giving me feedback, sending me emails, and helping me understand things that maybe come across a bit weird or could do with sharpening up, and I really appreciate you taking the time to do that. Feel free to fire off questions, emails, etc. Anyway, getting on with it. Etomidate. I'm sure we've all used it. I can say that I've seen it used once. My only thought was, this seems to take a long time. However, it has useful properties and a number of downfalls. So, what is it? It is a carboxylated imidazole derivative, and it is an ester. When was it synthesized? In 1964, and it saw use clinically from 1972. How does it look? The vintage option is a clear, colourless, aqueous solution with 35% propylene glycol. Its pH is 5.1. The modern millennial vibe is a milky lipid emulsion with a pH of 7.6. So it can look a lot like propofol, although it comes in a different concentration in a different size ampule. So you shouldn't make too much of a mistake there. It is clinically used in its enantiomer pure form. It's R enantiomer, and it is, for those who are superbly riveted to know, its molecular weight is 244.29 grams per mole. Mechanism of action. As you might guess, it messes around with GABA A receptors. Noting that Etomidate obviously has a chiral center, that's why you've got an R and an S enantiomer. The R enantiomer is 10 times as potent as the S enantiomer. pKa. This pKa is 4.2, and in some texts it simply describes it as very hydrophobic at physiological pH, which you could sort of presume because we've had to make an acidic preparation with propylene glycol to make it soluble in water, and it stings when you use that, versus our novel millennial lipid emulsion, pH of 7.6, doesn't sting because A, not acidic, B, nice, gentle lipid emulsion without the propylene glycol. That will be important later. If you look on the internet for pKa and unionized fraction for Etomidate, not really much there, but our Handbook of Experimental Pharmacology, which is biblically interesting, but perhaps not completely useful for the FRCA primary exam, does have its moment. So I can tell you that Etomidate is 99% unionized at physiological pH, and this also fits when you try and stick it in a Henderson-Hasselbalch pKa calculator. But we'll get into pharmacokinetics more later. Dosing. So generally speaking, intravenous is the route here, although there is some information that it's been used rectally and transmucosally to achieve sedation, much like thiopentone has been used rectally. Not first line, folks. The IV dose of Etomidate is 0.3 milligrams per kilo, ranging from 10 to 65 to 150 seconds to reach effect, depending on what you read, lasting for 6 to 10 minutes. So in our 75 kilo adult, you'd give them 22.5 milligrams. In old folk, you might be inclined to use a lower dose, but we'll get into pharmacokinetics more later. It's always important to divide questions on drugs into pharmacodynamics and pharmacokinetics. Dynamics, as we know, is the effect the drug has on the person. Kinetics, when you're thinking about effects, you could simply break it down into organ system, but it might be worth pointing out that the chief effect of Etomidate is inducing hypnosis and general anaesthesia. Its cardiovascular effects. It is incredibly stable cardiovascularly. It will cause a very slight drop in systemic vascular resistance and cardiac output, but it doesn't alter your cardiac oxygen consumption or supply very much at all. In unstable coronary artery disease type patients, it's a great choice. One paper did note that patients with valvular disease, like mitral valve regurg, seems to see a slightly worse drop in blood pressure. But you're going to expect that across any drug, and Etomidate, I think, still causes less of a drop. Of note then, it has no role in obtunding any sort of response to laryngoscopy because it's not dropping blood pressure. Respiratory wise, so you get a dose related drop in respiratory rate and tidal volumes. Sometimes you can get a transient apnea and you may see coughing and hiccuping, and that's part of this spectrum of involuntary movements that we're going to talk about in a jiffy. GI effects. If you're using the propylene glycol vintage preparation, then 2 to 15% of patients were getting post-op nausea and vomiting, and if you were also using opiates, that went up to 40%. Although the opiates, when this study was done, might have been morphine or pethidine. Whereas the lipid emulsion version the millennial delight, has a similar incidence of post-op nausea and vomiting to propofol. Great. What about CNS effects? So we know it causes hypnosis, general anaesthesia, but also patients can end up in a bit of a weird situation, and this is a spectrum of having involuntary muscle movements, IMM, involuntary muscle movements. We see this with a lot of general anaesthetic agents, the twitchy epileptiform movements of propofol, etc. The increased laryngospasm risk with thio. We end up in a situation where we might be modulating different parts of the brain at different times and ending up with inhibited circuits and disinhibited circuits depending on where you're putting the brakes on. Patients can end up with tremors, myoclonus, and again, I mentioned coughing and hiccuping, so they can be a bit jerky. Naturally, this would be fixed by paralysing the patient. Etomidate also drops intracranial pressure, drops intraocular pressure, and decreases cerebral blood flow by 20 to 30%. 20% of patients would have epileptiform changes on their EEG, but we know this doesn't quite really mean epilepsy. But what about the metabolic consequences of Etomidate? Because that's really where the money is, isn't it? Once upon a time, they did not know that Etomidate impairs steroid synthesis. Patients were dying because of this. We're going to talk about the history in a moment. Etomidate is an inhibitor of adrenal, 11 beta hydroxylase and 17 alpha hydroxylase. These are two of the most critical enzymes used in your steroidogenesis pathway. Talking about them that in a mo as well, folks, don't panic. But what does it cause? It causes depressed levels of cortisol and aldosterone for 24 to 48 hours post-dose. A single dose has an effect, an infusion has a bigger effect. You could say, and there are a few suggestions that, well, this probably isn't an issue in a healthy person, but then a healthy person would tolerate an other anaesthetic agent, so why would you pick one that bonks their cortisol on the head? If you have low cortisol levels, you feel like arse. When you're doing your night shift and the sun comes up and you look outside and you're like, oh, wow, I feel a bit better actually. Oh, the end is nigh. That's because you've seen blue light in your eyeballs and it's stimulated your body to produce cortisol and you feel better for it. Imagine taking that away. It'd be like making the patient do a night shift the day after their operation. Poor buggers. And what about toxic effects of Etomidate? So with our Yonder Vintage preparation, 25 to 30% of patients got pain on injection. And this is probably in part because of the pH and the propylene glycol is actually a big offender here. Don't give someone with porphyria Etomidate, not compatible. So Archie Cochrane of Cochrane Library Research Meta-Analysis fame, he wouldn't have done well with Etomidate. He had porphyria. Now, an interesting segue in toxicity before we get into the pharmacokinetics. One of the papers I read before producing this show pointed out diligently, in comparative manner, the LD50 of Etomidate versus other anaesthetic agents, saying, gosh, if only we could use it, it is so incredibly safe. The LD50 of Etomidate is 26 times the ED50 dose. That's cracking. That means that you could really draw up 26 times the dose you needed to give before you'd actually kill a patient with Etomidate. So there's a huge margin for error. But folks, we actually use drugs at their LD50 dose daily. Can anyone guess what the LD50 for rocuronium is? And we're going to think about this in milligrams per kilo because it's easier than fractions. The LD50 to kill a rat with rocuronium is 0.3 milligrams per kilo. Now, what might you imagine is the therapeutic dose to achieve paralysis to ventilate a rat? Well, 0.3 milligrams per kilo. So using the argument, well, Etomidate has got an excellent therapeutic index of, treatment dose versus lethal dose, kind of doesn't really work when you're an anaesthetist and you're actually using poisons for your nefarious anaesthetic intentions. Curiously, propofol, the index is about 3 to 4. So, if you're using 1 milligram per kilo in Mildred and you accidentally use 3 to 4 milligrams per kilo, then you might kill Mildred. Is this because of apnea or cardiovascular collapse? Well, who knows? But let's just remind ourselves in a define or die moment, because we're bringing it back, what ED50 and LD50 is, just in case it comes up in your exam. ED50 is the dose that achieves your desired therapeutic response in 50% of the population you administered it to. So if you had 10 people and you all gave them a milligram per kilo, and then half of them were nicely asleep and you could prod them and they won't be bothered, and that was your therapeutic target, then that's your ED50. LD50 is the dose that kills half your tested population. So here we go, we've got 10 people and we give them all a milligram of propofol per kilo, and and half of that cohort die, then a milligram per kilo is your LD50. Now we find ourselves in a situation where we now know what an LD50 is, and an ED50 is, and we've realised that actually we're knocking about administering lethal doses of drugs on paper, but our patients aren't dying because we are intervening. Before we move on, let's think, would Etomidate be an optimal sedation agent for endoscopy if it didn't cause impaired steroidogenesis? We know that its blood pressure stability is excellent. We know that we get a dose-dependent response to reduction, in breathing and tidal volume, but it doesn't completely impair this. So you'd have a breathing unconscious patient. What's the stickler? Well, you could do this. It's a pity it messes up your cortisol, but as long as your surgeon or endoscopist doesn't mind 20% of their patients jerking, hiccuping, having a spot of myoclonus now and again, then it would be a great agent for that, wouldn't it? But I can imagine the look on their face as they're trying to stick an endoscope down someone and they're jerking around in a myoclonic manner. Very pesky. Okay, kinetics, because we don't want to get in the long grass here. Absorption, well, it's IV dosing, folks. I could not tell you the rectal bioavailability of Etomidate, so let's not go there. We could probably figure it out, though. Maybe we could have a little thought thing at the end of this. Distribution. So it's 76.5% protein bound, almost entirely to albumin. It crosses the placenta. Its volume of distribution, 4.5 litres per kilo. So reasonable. It's quite, it spreads out quite a lot. I've mentioned its pKa, 4.2, and then at physiological pH is 99% unionized. So there's a massive fraction that can pile across those lipid membranes and get where it needs to go. Metabolism of Etomidate. I mentioned earlier it's an ester. It is chiefly broken down by hepatic esterases into an inactive carboxylic metabolite. A teensy bit of plasma esterase activity seems to get involved, but it's almost chiefly the liver, folks. 75 to 87% excreted via the urine as its metabolite. 2 to 3% unchanged in the urine. If you are clever and you're thinking about 3 compartmental models and plasma half-lives, I know this kind of crosses into metabolism here, guys. Its plasma half-life is 2.7 minutes, but its V2 and V3 compartment half-times, the things that influence that decay curve, 27 and 275 minutes respectively. Excretion is prolonged in cirrhotic patients, and of interest, it has been withdrawn in use in the United States, the Republic of Ireland, Canada, and Australia. But the Brits, we like to be different. Why was it withdrawn? Well, I hope you already know that it's because we've stumbled across the unfortunate reality that it knackers steroid synthesis, and folks in ITU were faring very poorly for that knackering steroid synthesis effect. The first time this was reported was by Ledingham and Watt in 1983, and they'd observed in their sort of ITU trauma patients that those who were mechanically ventilated and sedated with Etomidate were 69% of those were dying versus the 25% who were sedated with benzos on their unit. That's bad news, isn't it? I think there were 1 or 2 other studies, and then it was rapidly withdrawn as an agent of choice in intensive cares and ended up being withdrawn in use when it came to induction of anaesthesia. One of these studies found that if you actually gave a patient steroid repletion alongside their Etomidate infusion for sedation, their incidence of death diminished and returned back to at least somewhat back to their baseline odds of death. What about a single dose of Etomidate? Is a single dose of Etomidate okay? Well, 1 dose led to 6 to 8 hours of adrenal suppression. They found that the dose to achieve sedation, i.e. the ED50 patient snoozing dose, is quite high, but the ED50 to trigger adrenal suppression is quite low. I think the plasma concentrations were 400 milligrams per mil or 10 milligrams per mil respectively. And actually some folk have reached for Etomidate to treat severe Cushing's when you need to stop their steroid synthesis, because you only need to give them a tiddly tiny bit. Fortunately for us, propofol isn't the only option in our armamentarium. We could give thio and ketamine, and there are some lab-based boffins out there trying to develop newer analogues of Etomidate that eradicate the steroid synthesis issue whilst maintaining that delightful cardiovascular stability feature. Are they going to be able to prevent that myoclonus? Who knows? It really depends on receptor selectivity, blood flow to which bit of the brain that seems to end up inhibited before other bits of the brain. It all gets very confusing. But Miller's Anaesthesia has a section on effects of anaesthetic drugs that does talk in more detail about these inhibitory interneurons that get inhibited, leading to the tracts that they were inhibiting getting all lively and feisty. Not for today. What is for today, as a finishing off, is we're going to talk a little bit about steroid synthesis. Now, eventually, GasGasGas is going to make it towards physiology, but as physiology is my most favourite subject, I could see myself spending a lifetime on it, so we're not going to go there yet. There are 3, maybe 4 steroids that we're chiefly interested in a human, but actually there are like a bunch of other steroid-like molecules that are involved in the body in varying concentrations. But the ones we're interested in: cortisol, a glucocorticoid; aldosterone, a mineralocorticoid; androstenedione, which is a sex or androgen-like hormone; and sometimes dehydroepiandrosterone, which is a precursor to the androstenedione. That's pretty much all I'm going to talk about when it comes to sex hormones. That's for another time. What is the common precursor to all these hormones? Well, it's cholesterol. Steroid. Cholesterol. Cholesterol. This is derived from the LDL that's circulating around in the plasma that is provided by your liver and the fatty synthesis liver pathways that exist, and, lipoproteins and all that jazz. We know that there's a number of enzymes involved in achieving cortisol, aldosterone, and androstenedione from this precursor. And now we need to also think, before we go into that enzyme pathway, where do these things magically happen? Well, they occur in the adrenal cortex. So remember, we've got the adrenals that sit on top of the kidneys. There's 2 chief components to it. The adrenal medulla, this looks a lot like a sympathetic ganglion, and it spaffs out catecholamines when stimulated. And the adrenal cortex, the outer bit of the adrenals, that is involved in steroid synthesis. Now you can break down the cortex into 3 things. The acronym is GFR, superficial G, D, R, and it is zona glomerulosa. This makes aldosterone. Zona fasciculata makes mostly cortisol, teeny bit of androgen, and zona reticularis, tiny bit of cortisol, a lot of androgen. What influences them? Well, your glomerulosa is influenced by angiotensin II and plasma potassium concentrations, because why would it not be interested when it's the thing that modulates a lot of your plasma potassium concentration? Your fasciculata, well, we all remember the hypothalamic pituitary adrenal axis. It is influenced by ACTH, adrenocorticotrophin hormone, from the anterior pituitary. And we're not doing the reticularis, don't worry folks. Cortisol is converted to pregnenolone. That's like the common, I'm going to be made into another steroid molecule, steroid. If in doubt, in an exam, you need to choose between either 17 alpha hydroxylase or 21 beta hydroxylase. I think it's pretty criminal to ask you about any of the other enzymes involved. If anyone asks you, how does aldosterone made? Well, it's from corticosterone made by aldosterone synthase. So, if they're asking you that question, then it's hopefully eminently obvious. If you lack cortisol, you're going to end up in an adrenal crisis. This could be due to Addison's or iatrogenic suppression of your own body's synthesis of cortisol because you've been smashing the prednisolone for months and months and months. Too much cortisol, you're going to look Cushingoid. Well, that was Etomidate with a brief look at ED50, LD50, thinking about how as anaesthetists we are using poisons safely on a daily basis, and how the LD50 is probably different for an anaesthetist than a non-anaesthetist in these drugs. And that might be an interesting thing. What is the LD50 of an anaesthetist trying to stop a rat from dying from propofol overdose, where it's intractable? I imagine it's quite high if you've got noradrenaline that you could possibly give to the rat, and if you could ventilate them. Briefly thinking about the absorption characteristics of rectal etomidate. So we've identified that hepatic metabolism does a great job of clearing etomidate, but we also know that the venous drainage of the rectum is 2/3 systemic and a mere 1/3 that ends up in the portal system. So your 0.3 milligram per kilo dose, only 0.2 milligram per kilo is actually going to end up in the systemic circulation. That third is going to end up mopped up by the liver. So you're going to have a lower dose. So perhaps its rectal bioavailability is somewhere around 66%, if we're presuming that it's got a rapid first pass metabolism for the drug that goes past the liver. And that was Etomidate. Cheers folks, thanks for listening. If anyone wants to drop me an email, crack on. I will see you next week when we're doing midazolam. Enjoy your weekend. I'll see you then folks. Thanks for listening, guys. I hope you found it useful, but if you found it awful, do let me know. Please like and subscribe, register with whichever podcast platform you find yourself using, and leave a comment if you think I need to square something away. I just want to make sure that you guys know that every day you are getting better at this. There is a bucket of content to try and consume, and it is like drinking from a fire hose. Take it day by day, don't overcook yourself, don't freak out, and keep studying.